Professor Cooperman is here, so that means everybody's here. And
good morning, everyone. Hi, Michael. Welcome. We appreciate your being here. Very kind of you.
Very great to see you.
Always a pleasure.
I believe that everybody's here. Even Kathy is here on time. That's really amazing.
Now, be nice.
So today we have a very, very special presenter. He's a director of the Eye Institute. And the Eye Institute was formed in, I believe, in 1968 by Congress that instituted this new institute. And there were only two directors before Michael. The first one was Karl Kupfer, who was a founding chair of Department of Ophthalmology at the University of Washington, and then Paul Seaving. So we're truly delighted to have a new blood in the Eye Institute, and the fantastic choice that has been made to appoint Michael to this position. So without any delay, we'll move to Sam.
Good morning, everyone. My name is Sam Du, and I'm a MD PhD student in the Palczewski Lab. It is my great honor today to introduce Michael Chiang as today's distinguished speaker, who will be speaking today on the use of artificial intelligence in ophthalmic care. He's not only a clinician scientist, but the director of the National Eye Institute at the National Institutes of Health since 2020. He received his BS in electrical engineering and biology from Stanford University, his MD from Harvard Medical School, and Master's in Medical Science from the Harvard-MIT Division of Health Sciences and Technology, and a Master's in Biomedical Informatics from Columbia University. His clinical training in ophthalmology and fellowship in pediatric ophthalmology was done at the Johns Hopkins Wilmer Eye Institute. From 2001 to 2010, he was the Ann S. Cohen Associate Professor of Ophthalmology and Biomedical Informatics at Columbia University, where he was the Director of Medical Student Ophthalmology Education and Director of the Introductory Graduate Course in Biomedical Informatics. In 2010, he moved to OHSU in Portland, Oregon, where he was a Knowles Professor of Ophthalmology and Medical Informatics and Clinical Epidemiology and Associate Director of the Casey Eye Institute. He directed several training programs at OHSU and has mentored over 50 postdoc fellows, medical students, and graduate students. He has chaired and served on numerous American Academy of Ophthalmology committees and boards, and has served as an editor for multiple journals, such as the Journal of the American Medical Informatics Association and Ophthalmology. His research career has focused on the use of biomedical informatics in clinical ophthalmology, and his contributions include multiple influential papers on retinopathy of prematurity and an AI system for retinopathy of prematurity that received breakthrough status by the FDA, among other fields of clinical practice. His expertise in informatics and big data that he brings to NEI is a huge benefit for vision science and ophthalmic care in the US and worldwide. Please join me in welcoming Dr. Chiang, NEI Director, to our seminar series.
Well, Sam, thanks for that introduction. And Kristen Grajna, thank you for the invitation to come here. We've been chatting a little bit in the Zoom before 8:30 Pacific. And, I just, one of the things we talked about then is that, I wish we could do this in person, and we'll look forward to being able to see all of you, in person. I'm just scrolling through the names of the participants here. And there are many people that I sort of, know, and many of whom are actually quite close friends out there, and it's thanks for coming, really. What I in talking with Grajna before, I just thought what we do is basically give a research talk. I'll talk a little bit about NIH and some of the stuff that we're interested in at NIH and particularly NEI, but really want to focus this on research. And as Sam mentioned, some of the stuff that I've gotten interested in over the years has been in artificial intelligence, and so that's what we'll basically talk about. I've called this Artificial Intelligence in the Future of Ophthalmology, Promises and Challenges. And this is a disclosure slide, and really, I don't have any financial disclosures. I'm a U.S. government employee. Now most of the work that I'll be describing here was done when I was in Oregon, and I did have some relationships then. They're listed on the slide here. And most importantly, I'll be talking about some work that many people contributed to, and I'll try to highlight them along the way. Especially want to call out Pete Campbell, who's a retina specialist in Oregon, and Susan Osmo, who was a study coordinator there. But a lot of different collaborators here. And what I'm going to try to do is make this talk generic in terms of artificial intelligence. I'm going to focus the examples on retinopathy of prematurity because it happens to be the disease that I study. I'm a pediatric ophthalmologist by background. And so we'll talk about specific examples in ROP, but try to highlight where they're generalizable across all of eye care. So why do we care about ROP? Well, it's one of the leading causes of blindness among kids in the US and also around the world. There are roughly 32,000 cases of significant visual impairment or blindness each year throughout the world. And almost all those cases are preventable if they're diagnosed early and if they're treated appropriately. Okay, so those are going to be the challenges that we'll talk about, sort of early and appropriate diagnosis. Just a little bit of background. The way that you diagnose ROP is that you do an eye exam. You basically look at the retina and you describe what you see. The disease came around, it started really in the 1940s and 1950s. And how come 1940s and 50s? Because before then, premature babies didn't survive long enough to get ROP. And so traditionally back in that day, you basically looked at the retina with an ophthalmoscope and used words and drawings to describe what you saw. So classic ophthalmic diagnosis. And in the 1980s, that changed with the International Classification of ROP, or the ICROP. Okay, and there's actually a current, there have been 2 revisions, 1984 and 2005, and there's a third one that's coming out right now. But what this international classification does is it creates a standardized terminology, and clinicians will use words like zone, stage, clock hour extent, and plus disease to describe what they saw. So instead of words and pictures, it's these terms. And when everybody in the world speaks the same language, you then have an international standard for doing clinical eye exams, and you also have an infrastructure for doing multi-center clinical trials. And so from doing those clinical trials, we know that of all these different parameters, something called plus disease is by far the most critical one for knowing when you have a baby who is at risk for going blind. So if a baby has plus disease, you need to treat the baby because the baby can go blind. And so what's plus disease? It means tortuosity of the arteries and dilation of the veins in the central retina. Okay, so remember those terms. Plus disease is bad, you need to treat, and that means tortuous arteries and dilated veins in the central retina. Okay, so that's the benefit of standardization. Now, one quick segue, because I know a lot of this is a research audience. There are a lot of challenges in terms of taking care of babies with ROP. When I started my practice in 2001, the American Academy of Ophthalmology with the American Academy of Pediatrics and the Pediatric Ophthalmology Societies came up with guidelines. Okay, they publish these every 5 or so years. And at the time, those guidelines says you've got to do these eye exams using indirect ophthalmoscopy because of that standard classic eye exam. And that's not an easy thing to do. Okay, there's a significant travel time, coordination time, because doctors have to travel to neonatal intensive care units to do this. And the exam is really difficult and subjective and imprecise. And we'll talk more about that. There's enormous medical legal liability, okay, the biggest in all of ophthalmology. And not a whole lot of ophthalmologists willing to do this. Okay, you get paid very little money for doing this, as an aside. And so as an approach, there's very limited access to care, even in this country, okay, let alone internationally. And so early in my career, I got interested in, can we use telehealth? Can you train nurses to take pictures of the retina and then diagnose it remotely based on that? And so this is how I started my career. There have been a number of studies in this area, actually quite a few, basically showing that the accuracy of doing a so-called telemedicine exam compared to if you were to walk up to the bedside and do a classic ophthalmoscopic exam, they agree very closely. Okay, sensitivity and specificity, very high. Okay, so So this has been shown in many studies. Here's an NIH-funded multi-center trial done at the University of Pennsylvania showing that, Graham Quinn's group. And so as a result of those studies, basically you can look at a picture of the retina, get the correct diagnosis. There have been a number of real world programs that have popped up over the past 10 years, 10, 15 years. And so it happened that in 2013, I was part of a American Academy of Ophthalmology, American Academy of Pediatrics, an APOS set of guidelines, the ones that they do every 5 years. And what those guidelines said in 2013 was digital remote interpretation is a developing approach to ROP screening. At minimum, the programs that employ this method should comply with the recommendations here. Okay, and so it took about a year to write that sentence. Okay, the American Academy of Pediatrics is very picky about wordsmithing things, especially when there's legal implications. But really, what this says is that you can do telehealth for ROP, but you have to be careful. Okay, and when I reflected back on 2013 compared to 2001, I thought, well, that's a huge change because now this is saying that you can do telehealth. The lesson that I took from that is that you start with a clinical need. In this case, it's tough to do those eye exams. Okay, people do the research studies. You get early adopters. Makes its way into policy like this, and then you get an evolving standard of care. And I actually thought that was fascinating. I mean, it's kind of what we do in the academic centers. But I think it's fascinating to see this sort of play out. And I just wanted to highlight that because I know we're here at a research forum, and isn't this a nice sort of model for how all of us are working? Okay, so I want to just now talk about diagnosis. We made the conjecture earlier that ROP diagnosis is subjective and qualitative. And in 2007, did sort of an embarrassingly basic study where we took images of the retina, we put them on a website, and we just asked experts around the world, can you diagnose this image? Is it plus disease, is it pre-plus, or is it normal? Okay, so bad, intermediate, or okay. And here's an example. This image here, there's a little bit of tortuosity, there's a little bit of dilation of the vessels. 50% called it plus, 50% called it not plus. And we had a lot of images split 50-50, 60-40, 70-30. And so intuitively, this is a problem, that if plus disease is so important that it's the basis of treatment or not treatment because babies are going to go blind, why are the world experts splitting 50-50? Okay, so I want to talk about, use that to segue into the process of diagnosis. Now, we've got these terms, the science and the art of medicine. So I was on a panel, it was probably about 2010, with a retina specialist in your part of the country, Los Angeles, Tom Lee. And Tom on this panel made the analogy that there was a US Supreme Court justice in the 1960s, Potter Stewart, and they were arguing a case in the Supreme Court on pornography. And Potter Stewart says, well, I can't define pornography, but I know it when I see it because it just looks bad. Okay, and so Tom made the argument that plus disease is like pornography. You can't define it, but it just looks aggressive. Okay, so you know it when you see it. And that comment bugged me for months because I thought, well, if we want to be scientific about things, how can we just be saying that it just looks bad? But on the other hand, every clinician knows that sometimes things just look bad. Hey, I don't like the way this retina looks. I don't like the way this corneal ulcer looks because it just looks bad. And so we got interested in this concept. Could some of this variability in diagnosis, like we're seeing on the previous slide, be because of variability in the diagnostic process? In other words, if everyone has different concepts of what it means to just look bad. And so we had a visiting fellow, Nina Hewing from Germany, and we designed some studies where we thought, well, let's try to capture and encode the detailed qualitative thoughts of the 7 most seasoned experts in the world. Okay, we tried to find people who came up with that original international classification system, the original definition of plus disease. And we spent months designing protocols where we selected images, okay, and basically videotape them while they talk through those images. Okay, tell us what you're thinking, and use a pen and annotate the parts of the retina that either worry you or reassure you about that image. And so we had a cognitive psychologist go back and model what their thought process was. And so here's an example. This one image, one expert diagnosed it as plus, one expert diagnosed it as pre-plus, one diagnosed it as normal, and they're all looking at different parts of the retina. Okay, and so I suspected at the time this was true in every field of ophthalmology and possibly every field of medicine, that there's not always consistency in what people are really thinking when they make that diagnosis. So it happened that in looking at the literature, there was an ophthalmologist who was the chair of the University of Michigan, who was a glaucoma specialist, Paul Littker, who back in 1976 wrote a paper on variability of expert observers in evaluating the optic disc in glaucoma. And so Paul Littker in 1976 was talking about a significant amount of variability exists between observers in designating the cup to disc ratio, which is how you evaluate the optic disc. Further, different methods are used for evaluating the size of the cup. One method uses combination of contour and color, the other uses contour and pallor, ... And so to me, this, we thought we did something really interesting in 2013, but it was striking that Paul Littker was thinking about the exact same thing in a different disease back in 1976. Okay, so I do think that this is something that's generalizable. When you get different experts to look at different images and come up with diagnoses, a lot of interesting things comes up along those lines. So Pete Campbell in Oregon did what I thought was a really, really nice set of work, where it had 8 experts. Okay, these are world experts. Look at 100 different images. Okay, and these are all ROP images. And the way to read this is that if that expert diagnosed that image as plus disease, in other words, bad, it's in red. If that expert diagnosed that image pre-plus, the box is yellow. And if that expert diagnosed it normal, it's in green. Okay. So the first thing to notice is that experts number 7 and 8 here diagnose plus disease 6 times more often than expert number 1. Okay. And if you go to a different data set here, 7 and 8, it's that same 6-to-1 ratio. And so we've got overcallers and undercallers, and every clinician knows this, that there are some docs that are more aggressive. I'm always going to operate on you, and there's some that are more conservative. We're always going to do medical management. And in this case, these data plus pre-plus normal, they've been used as the basis for multi-center, NIH-funded clinical trials that form the basis for practice. Yet we've got this discrepancy between what doctors are diagnosing. Now, the other thing to note is that if you take each image and give it a score, okay, so give it 1 point for normal, 2 points for pre-plus, 3 points for plus, and average it out among these 8. If you convert it to a color, okay, that's what it looks like. And so on this end of the spectrum, these images are really, really green because everyone diagnosed normal. Down here, they're really red because everyone diagnosed plus, and you've got every color in between. Okay, so the real world is a continuous spectrum of abnormality. And when we do evidence-based medicine, there's this implication that patients come in buckets, like normal, mild, moderate, severe, but people don't. They come on a continuous spectrum, and clinicians need to draw the lines between normal and plus and pre-plus, for example. And we're not very good at doing that. Okay, some people draw it here, some people draw it here, and intuitively, that's kind of the motivation for artificial intelligence. Now, one could criticize this work and say, well, we've got the wrong 8 so-called world experts. It happened that we recently went through this 3rd edition of the International Classification of ROP, and we got supposedly the 34 most prominent world experts out there, from 17 different countries around the world. And we did this experiment here, and it was that exact 6-to-1 ratio, okay, among those 34 world experts. Okay, so and I suspect this is a problem in really every field of medicine. Now, the one thing that we are good at is we're not very good at absolute diagnosis, plus, pre, plus, or normal. Okay, some people draw the lines here, some draw it here. But if you ask people which is worse, number one or number two, we're actually much better at relative comparisons. So these are weighted kappas. 8 experts, what's your diagnosis? Plus, pre, plus, normal. Darker is better. And we're really not very good at agreeing. And that's the basis for the red, green, yellow plot. But if you ask people which image is worse, number one or number two, these are correlation coefficients, darker is better. We're actually much better at that relative comparison. And in fact, if you go through and compare for 100 different images, if you have experts do thousands of comparisons, 1 versus 2, 1 versus 3, and do ELO ranking, okay, the way that the way that they rank chess players, for example, based on who you beat. We actually, people agree very closely in terms of relative comparisons. And so I'm going to come back to that sort of relative comparisons versus absolute comparisons. But so we talked about this continuous spectrum and putting things onto a scale from worst to best. This is one effort to do it. Jayshree Kalpathy-Kramer, very close collaborator, worked with Pete Campbell on these projects. And, these are 9 images from worst to best. And how do we know this is worst? Because of 8 experts, all 8 called this plus, 0 called it pre plus, 0 called it normal. Okay, this one in the middle, 1 called it plus, 6 called it pre plus, 1 called it normal. And down here, everybody called this normal. Okay, nobody called it plus or pre plus. And so, so we thought, well, let's come up with 9 standard images and, let people use them from comparison. And we actually wrote a mobile app that we called iRop Assist that you can actually still get on Apple Store or Google Play. And the idea is that the user uploads a picture or takes a picture of their image, and you swipe right or swipe left until you find the image here that most closely matches with your image. So taking advantage of the fact that relative comparisons may be better, maybe easier for people than absolute comparisons. Okay. So, so I want to just, that's kind of what I would consider motivation for something like artificial intelligence. And I just want to talk a little about some of the work that we've done. And I hope that some of this concept comes across, that these ideas are generalizable across different ophthalmic diseases. Now, in AI, everybody knows that in the late 1990s, IBM worked on a project called Deep Blue that played chess, and it could basically, through brute force, think more deeply and faster than even the world chess experts, and could beat basically all the best chess experts in the world. What's a little bit less known, and I don't know why, is in 2017, DeepMind, a think tank in the UK that was eventually purchased by Google, worked on a project called Alphago. And the Alphago project was training AI systems to play Go. Now, Go is an Asian board game. And as you progress in the game, the number of moves increases exponentially. And so you cannot, even with modern technology, brute force this. There's just too many possible moves. And they basically use deep learning to train AI systems to pattern them after the thought process, like what would a given expert do under a given configuration of the board. And so we're able to train systems to play Go better than the world experts. Okay, and that was a real coup. Back in 2017. Now the more interesting thing is that they then developed a system called Alphago Zero, and the premise of that was that they gave the systems the rules of the game, but not any information about what different experts would do under different configurations. Instead, they used a technique called reinforcement learning, where they had 2 systems play each other, just knowing the rules of the game. And essentially, the systems taught themselves how to play Go. And in a very short amount of time, they could beat essentially all the world experts in Go. And I thought that was a fascinating premise. And it's actually a scary premise. But the obvious question is, well, how can we take advantage of that to build systems that can help doctors take better care of patients. Okay, and so AI for ophthalmology, I think most of you will know this. There's been an enormous amount of work in AI for ophthalmology. I captured this screenshot of a tweet by Eric Topol. This is about a year and a half ago. Of all the medical specialties, most people think radiology is leading the AI movement, but it's actually ophthalmology. And this is along the lines of some of the stuff that we were talking with Chris and with Sam before we started here. A lot of innovation. And Michael Abramoff at the University of Iowa, his group developed the first FDA-cleared autonomous AI system in any field of medicine for diabetic retinopathy. And many of you, maybe even most of you, know that there's been beautiful work by the Google Health group with knowledge discovery involving systemic health. And this is from their paper that they were able to train these deep learning systems to predict the age of a patient based purely on the retinal image, and within plus or minus a few years. And for most ophthalmologists, that's not entirely surprising. That we can look at an image and see if it comes from someone who's relatively young versus relatively old. Now, maybe plus or minus 2 years, that may be better than most of us can do. But they actually were able to train systems to tell whether the retina came from a male patient or a female patient. And most people in ophthalmology thought that was fascinating. Just because we can't look at an image and tell whether it's male or female. Presumably there's some information in the pixels that gives that. And so the question is, can artificial intelligence be used for knowledge discovery and teach us more about things that we wouldn't naturally see, give us biomarkers for disease that we weren't really aware of? So a lot of potential there. But one of the things that I've really benefited from in my career is collaborative research. And Jayshree Kalpathy-Kramer, Stratas Ioannidis, and Dennis Erdogmas are three basically computer science faculty. Jayshree's at Harvard, and Stratas and Dennis are at Northeastern University. They've got their team of PhD students. Okay, we had our team of PhD students and clinical trainees in Oregon. And we met every single week for 2 hours by video conference for 7 years or so, and met probably 3 times a year for a few days at a time. Sometimes we take special trips. Sometimes just tag on a day at conferences. But I really, these folks are basically what I'd call pure methodologists. Who don't work in the eye except for the work with us. And I learned a lot about sort of innovation and sort of moving things forward from working with these folks. And so I just wanted to put that out there in terms of the process of doing science. And one of the things, we designed up a lot of studies looking at artificial intelligence for diagnosing ROP, specifically plus disease in ROP. And one of the things we talked about is, well, if all the experts, even the world experts, come up with different diagnoses when they look at a retina or look at an image, how do we come up with ground truth for training these systems or for evaluating them? And this was the method that we used. Mike Ryan, who was a medical student in Oregon, wrote the paper on this. But basically, over years, we recruited thousands of patients for these studies. Every baby got an eye exam by an expert at the bedside. And of course, we would record all the different parameters. And every baby got photos that same day. And we'd have 3 different experts read each of those photos independently and basically harmonize all these diagnoses into a consensus gold standard. If they didn't all agree, we had methods of coming together and as a group deciding what was the most likely ground truth diagnosis. And it's not a perfect diagnosis, but we felt that it was the best that we could do to get a consensus reference standard. And that's what was used to train and evaluate all of these studies. Have worked with James Brown, was a postdoc at Harvard, and Pete Campbell was a junior faculty in Oregon. and built deep learning systems for looking at ROP and plus disease. And so how did this particular system work? Well, it was a two-stage process. We take that image and build a convolutional neural network to come up with a vessel map. Okay, so take this and basically segment it. And why would we do that? Well, we thought these pigments, some patients have dark pigmentation, some have light pigmentation, and we thought there may be some racial bias potentially in terms of analyzing these images or how these systems would work for diagnosing. And so we just sort of made the postulate that we would go based on the vessels and remove that bias. And then once we've got that segmented vessel tree, we take that, put it through a second convolutional neural network to basically map that into feature space. Is it plus, pre-plus, or normal based on that consensus ground truth diagnosis? And so with that two-stage process, came up with systems that actually have very high accuracy for identifying plus versus pre-plus versus normal. And in fact, if you compare that to independent data sets, independent groups of these 8 experts, we actually found that the system beat all of the experts except one in diagnosing plus versus pre-plus versus normal. And this has been replicated in a lot of different diseases. And the fact that systems can perform comparably or better than even world experts, I think it's been relatively well established now across different diseases. One of the questions that often comes up, and what I want to do now is just go through some various things. How do we go beyond that, and what can we provide as added value based on artificial intelligence? And just some ideas here. One question that always comes up is garbage in and garbage out. What if you have an image that's of poor quality? Or how do you know if you have an image that's of poor quality that maybe you shouldn't be trying to do artificial intelligence on? And so Aaron Coiner is a PhD student in Oregon who was working with us. And we thought, well, let's train deep learning systems to grade quality. It happened that when we get graders to read these images, these are expert readers, we always have them read, is the image acceptable? Is it possibly acceptable, or is it not acceptable for diagnosis? Okay, and so well, let's train systems based on those labels. And so it turns out that when we do that, we can get systems with fairly high accuracy. Okay, areas under the ROC curves is basically 0.96 for identifying, do you have an acceptable quality image for diagnosis? And in fact, if we, what we did is we had 6 experts rank a set of 30 images from lowest quality to highest quality. Again, how do we do that? Through that ELO ranking mechanism, compare 1 versus 2, what's higher quality, 2 versus 3, 3 versus 4, 1 versus 3, et cetera. And based on that, we can rank images from 1 to 30 based on the consensus of experts 1 to 6 and also consensus ranking. And then we can have the convolutional neural network rank lowest to highest based on the outputs of the system. And it turns out that that system correlated medium well, 0.9 correlation coefficient with the consensus rank ordering. So it turns out, in a nutshell, you sort of can do this. And the disclosures that we've got a system that as Sam mentioned, we've gotten FDA breakthrough status for, and neither I nor anybody else in our group has any financial interest in these systems. And if we did, selling systems for ROP in premature babies, wouldn't be the way to make a whole lot of money. So anyway, we're diagnosing, we're incorporating this into that operational system. The one thing that we've gotten interested in recently has been, we made this premise that clinical diagnosis is subjective and qualitative. And that's true for ROP. It's true for a lot of different ophthalmic diagnoses. It's based on morphology, basically. And so the question is, can we go from subjective and qualitative to objective and quantitative and using deep learning? And so worked with Pete, with Jay Cherie, and with Sang-Jin Kim, who was a visiting retina specialist from South Korea. And so let's take the output of these deep learning systems and convert them to a 1-to-9 scale. Okay, so the probabilities of plus, pre, plus, or normal get converted to 1 to 9, and 1 is most normal, 9 is most abnormal. Okay, and why would we want to have a 1 to 9 scale? Well, from a clinical perspective, we talked about the fact that there's a continuous spectrum of abnormality, and the current classification system, plus, pre, plus, normal, or are you stage 1, 2, 3, is not really very granular. And for all practical purposes, you can't go week to week. And what happens is that we examine these babies every week in the neonatal ICU. And what you want to know as a clinician is my baby getting better, worse, or are they the same as before? And with a 3-level plus, pre, plus, or normal, that's not enough granularity to know if you're getting better, worse, or staying the same. And so maybe that 1 to 9 scale would give us more granularity to do that. From a practical perspective, I've heard very often from clinicians. I just have given so many of these talks over the years, and I always get this question: well, what's my medical legal liability if I use an artificial intelligence system to say that I've got plus disease, pre, plus, or normal? What if I don't agree with the system, and if I don't do what it said, am I liable medical legally? And I don't necessarily agree with that concern. In fact, I disagree with that concern. But I've heard it enough that I've started to take it seriously. And so we thought, well, maybe from a practical perspective, if the computer system gives you a 1 to 9 number, the doctor could then use that 1 to 9 number to decide what to do with it, with the same rationale that, well, blood pressure cuffs don't diagnose hypertension. Okay, doctors diagnose hypertension based on data that comes from blood pressure cuffs and from other stuff also. Okay, so we thought, well, maybe that could be the same rationale for a 1 to 9 scale. And so built out this scale. And I just want to give a couple examples of the benefits of, or what one might be able to do from moving from qualitative to quantitative. Okay, Travis Redd was a resident and then current faculty member in Oregon. And thought, well, let's try to see what would happen if we use this 1 to 9 scale for disease screening in ROP. And so took 4,000 some retinal images, calculated that quantitative AI vascular severity score from 1 to 9, and said, well, let's pretend we're using this quantitative scale as a screening cutoff for who needs to be referred for treatment. Who has treatment requiring disease. And so if we used a 3 on a 1 to 9 scale as a cutoff, that would have 94% sensitivity, 79% specificity. Okay, if we increase that cutoff to a 5, sensitivity goes down, specificity goes up. And so maybe this could have a rationale for just as an assistive device, or maybe we could use this system in resource poor settings. Okay, the developing countries, maybe there aren't enough ophthalmologists to go around, and so maybe something like this could be what's used for that first screening to refer babies for for care. Stan Taylor was a retina fellow in Oregon, and published up a paper involving what if we use this for disease progression. And what happened here is that we looked at 5,000 retinal images, again, calculated that AI-based quantitative score from 1 to 9. And so this graph shows that score from 1 to 9 on a cohort of those 5,000 some eye exams. Okay, and so there's 2 groups of patients here. The white bars here are the babies who never needed treatment. Okay, this is the much bigger group. Okay, the babies who were never treated because they never got disease that's bad enough. And that's probably 90% of the cohort. This is the 10% of babies who eventually develop treatment requiring disease, the 5 to 10%. And this is the age of the baby during the eye exam. Okay, so this is when you get your first eye exam. when you're 30 to 32 weeks post-menstrual age. These are premature babies. So this is really early on when you get your first eye exam. This is, as the babies are older, when babies need to get treated, this is around the time point they need to get treated. Okay, so when you get an older baby, of course, the babies who eventually needed treatment had higher quantitative scores than the babies who never needed treatment. Okay, it's good that it worked out that way, of course. Now, the interesting thing about this is that on their first eye exam, everybody had pretty low scores. And of course, on the last eye exam, these babies had high scores. But really early on, within a few weeks or within the first month, the babies who eventually developed treatment requiring disease had notably higher scores than the ones who were not destined to develop it. And so maybe if we can quantify, now you can't determine this from standard plus pre plus normal stage 1, 2, 3, 4, 5. But maybe if we can quantify this way, we can predict risk or identify who's likely going to progress. Maybe we can send them somewhere that they'll get higher level of care. So potential care delivery models that can come out of something like this. Kishan Gupta was a resident in Oregon and did a similar study but involving disease regression. So the way to read these graphs is that 5,000 babies, every baby gets a quantitative score from 1 to 9. Actually, this isn't 5,000. This is just babies. This is a few hundred babies who needed treatment with laser. Okay. So this is time 0 when the laser was actually done. This is a week before laser, 2 weeks before laser, et cetera, 1 week after, 2 weeks after, and so on. And so the orange here are the babies who were treated with laser only once. In other words, they started low, they got worse, had a high 1 to 9 score, got treated, and then they got better, and the disease just went away. Okay, so in other words, the quantitative score recapitulated what a doctor sees clinically. Okay, now the cohort here that's in blue is babies who needed retreatment with laser. And so on the average, what happened is that they also started low, got higher, got treated, improved a little bit initially, but then got worse again because they recurred and then were treated a second time and then got better. So again, it recapitulated what a doctor sees clinically. But the other thing to notice is that at the time of treatment, the babies who needed retreatment had higher quantitative scores compared to the ones who didn't. And so maybe if you can quantify like this, the question is that, well, maybe these babies didn't get fully cured with one laser because they got treated too late or for some other factor. And so maybe having this additional data from quantification can help us determine, well, what's the appropriate level for treatment? How do we study that? How can we do a better job of figuring out exactly when to treat? So, bottom line, a lot of benefits of this. Now, I want to just finish up with a couple cautions or unknowns. AI for medicine has been around for a long time. When I started my fellowship in informatics, one of my original mentors was a guy, Ted Shortliff, who was the chair of informatics at Columbia at the time, but he was a MD PhD student at Stanford in the 1970s and developed a system called MySim, which was a rule-based expert system that actually landed him in the National Academy of Medicine before he turned 40. Now, it turned out that the people who were his advisors at the time was an amazing group. Stanley Cohen, who eventually went to co-found Genentech, Joshua Lederberg, obviously Nobel laureate in genetics, and Edward Feigenbaum, who was a Turing Award winner, basically the Nobel Prize of computer science. And so this was an all-star cast. And they developed systems that looked at the etiology of meningitis. And I actually co-taught informatics with Ted at Columbia for several years. And these were slides that he used in these lectures. And basically it showed that back in the 70s, this AI system could basically do what we talked about with ROP. It could beat world experts in diagnosing etiology of meningitis. And in fact, dug this up, a New England Journal of Medicine perspective piece on artificial intelligence in medicine After hearing for decades that computers are going to assist with different difficult diagnoses, the practicing doctor may wonder why the revolution hasn't occurred. Skepticism is understandable. And it turns out that this was 1987, okay, from a group at MIT that this was written. And so I think, to me, the question is, what are the unanswered issues in AI, and how come this isn't, well, what's standing in the way of this being used for real day-to-day practice? And just building on some of the stuff that we've talked about, the performance of these AI systems improves as the task narrows. So in other words, if you ask a system, well, can you rule out plus disease? Can you tell me if a patient has macular edema? These systems are really good. But if you train a system for diabetic retinopathy diagnosis or for macular edema diagnosis, and you show them this central vein occlusion, they generally don't know what to do. So clinical diagnosis involves a lot of parallel tasks. And there are often many images per study, but they have a single diagnostic label. Okay, these MRI images, they all have the same diagnosis, yet there's a lot of different slices. And so, often we need to integrate clinical data and imaging data. Okay, so a lot of challenges here. How do we deal with this? Well, there are a lot of methodologies, but we really, I don't think, have figured that out. There are major challenges involving generalizability and bias. These systems often are validated using relatively homogeneous data sets from a few centers, okay, usually big academic centers. And in Oregon, for example, almost all the patients are Caucasian. And real world data is often poor quality compared to what you get from study centers, subject to many biases in data collection. Okay, we've a lot of racial bias, things related to social determinants of health. Really importantly, there's heterogeneity among different imaging devices. If you use a different camera, often those diagnoses don't translate. One system, they may have to get retrained, different races, different populations. And so, how do we deal with this? Well, we've got to build larger and more diverse data sets. We've got to validate across populations and devices. And ultimately, I hope we come up with better ways for data sharing. Now, this is something that's true for AI, and I think it's true for research in general, this concept of data sharing. And, we've talked about this. There's often unclear ground truth. Okay, we kind of beat this to death in terms of ROP, variability in diagnosis, variability in diagnostic process. Okay, a lot of people have been talking about AI for glaucoma. Well, we really don't have consensus in the glaucoma community about things like, what really constitutes moderate disease, severe disease. Okay, what do you look at? Do you look at the optic disc? Do you look at the visual field? Do you look at the OCT? What parameters do you look at? How do you find things like rapidly progressive glaucoma or risk of progression? And so I would argue that we need some agreement on those issues within the community before we can really move forward. One really important thing is that we've alluded to lack of standardization among imaging devices. These devices have a lot of data, a lot of quantitative data, and in general, you cannot get those quantitative data easily out of these devices. Okay, they're generally locked in by the vendors. And so, how do we deal with this? Well, consensus definitions, standards adoptions by vendors, a lot of potential approaches to this. And I just want to highlight, there's an NIH Common Fund project called Bridge to AI. There's 5 institutes that really developed this. National Library of Medicine, Genome, complementary health, and biomedical imaging, biomedical engineering and imaging. And the premise here is this is a grant basically to build data sets. The premise is that artificial intelligence is limited by the availability of robust data sets for training. And we may need data from multiple sources. Okay, we talked about imaging data in this talk. Well, there's clinical data, electronic health records data, a ton of omics data, maybe behavioral data, social determinants of health data, data from wearables. A lot of things could be integrated to come up with, to do artificial intelligence. And we need standards for data collection, and there are issues with training and education. And there is significant funding that's set aside for this, and it's on a really short timeframe. The funding announcement was released just a couple weeks ago, and it's due in August 2021. It's an other transaction authority, so meaning that it's somewhat of an expedited procedure. But if you're interested in learning more about this, this is the link, and you can just Google search "bridge to AI" and it'll be out there. But if you're interested, definitely check that out. NEI, we have a strategic plan, okay, and one of the what's in it for data science. One of the things that it's basically the things that we've talked about here. But if I had to, there's a draft of the strategic plan that's out there for public comment until Monday. Okay, and so if you're interested in that, check out NEI strategic plan. There's a request for information that's out there, and it's up on the web. The entire thing is posted, and let us know what you think. If I had to sum up the strategic plan for data science, it's basically we need to build larger, harmonized data sets, consistent documentation. In other words, making data AI ready. Got to have diverse representation, standards for data exchange. We talked about infrastructure for data sharing and code sharing. I don't know if this is going to be a federated system or a centralized system, but people are exploring both. How do we advance AI and technology in eye care? Well, maybe some of it's going to be cross-modality analysis, like we talked about with Bridge to AI. Combining things like imaging data, clinical data, omics data, social data. And ultimately, we've got to figure out, well, how are we going to improve quality of eye care and delivery of eye care? How can we improve health disparities? How can we build training and workforce development? So happy to talk more about this, but this is some of the things in a nutshell. I see one of my challenges as being how do we at NEI communicate better with the scientific community? And I've been trying to use Twitter as a mechanism for doing that. It's ironic that I'm in my screen here, I'm seeing Brian Jones, and he's a big Twitter person. And I love interacting with Brian on Twitter, but the real reason that we're doing this is to try to get information out there, because I used to always think, I never knew about that funding announcement. I wish I could have applied, but I never heard about it. And so I'm really hoping that we can get things out there. And so, just consider following that, because I really don't want to have people not apply for things because they don't know about it. And just a couple final slides that we've talked about the impact of technology on practice. Everything that we've talked about here is artificial intelligence, telehealth, qualitative to quantitative. And this is a gradual trend. And doctors, what they're seeing is electronic health records. It's changed the way that medicine and science works, and it's so gradual that I'm not sure we realize that it's happened. When I was in New York, I worked with a cognitive psychologist named Vimla Patel. And she did a fascinating set of studies that I just wanted to highlight here, and then I'll stop talking. The premise was technology affects cognition. And so she studied a primary care doctor in Canada. Okay, this is a primary care clinic in Canada. Now, this was before electronic health records. Part one of this experiment is that Vimla Patel goes to this practice and says, she gives them a piece of paper. They were using paper handwritten notes back then. Work up a patient and write me a note. Okay, and here's what the note looked like. Okay, a 74-year-old woman was diagnosed with diabetes in February. Complained of polyuria, nocturia, had high sugars. Got an eye exam. And so for any doctor, those of you who are doctors, this is what every doctor learns in medical school. You talk to a patient and you tell a story, a narrative story about what you heard. Okay, so classic medical documentation. medical thinking, if you will. So part 2 of the experiment is that clinic went to an electronic health record system. Okay, now this happened to be about 2000. This is what the electronic health record system looked like back then. It was basically a series of pull downs and check boxes, and little you type in your information here, and they had a drawing template, and so it really looks kind of like the EHRs that we have now, 20 years later. So part 2 of the experiment is the doctor got used to using EHR, and Vimla Patel goes back and says, work up the patient using your computer tools and write me a note. And here's what it looked like. Okay, completely different. It's structured instead of being narrative text. And for those of you who are clinicians, I think this is exactly what we see in 2021. Instead of that story, you're seeing checkboxes, and it's a computer template. Okay. So part 3 of the experiment is that the doctors used to using electronic health record systems. Vimla Patel goes back, gives the doctor a piece of paper, and says, write me a note. And here's what it looked like. Okay, and I thought this was fascinating because it's basically like, what I take from this is that the tools that we give to doctors to do their work affects the way they organize information. So it's not just about the fact that you're going from qualitative to quantitative, but I think that there's something fundamental about the way that we're teaching, the way that we're having people do things affects the way they do their job. And I think that there are much deeper implications for this, for the care process and for the diagnostic process. And so I've been trying to think this through, but everybody asks me this question, are machines going to replace doctors? It happened that, we talked about qualitative to quantitative. There's tools like artificial intelligence and OCT that when I was a resident in 2000, I had to learn to examine the nuance of the optic nerve or the macula using a contact lens. Nobody does that anymore. They do OCT, and it gives numbers. And so it happened that a couple of years ago back in Oregon, we had a resident research day, and we had 6 residents up on the stage. Some of them had done research with me, Pete Campbell. Some of them had done research with people like David Huang or Yali Jha involving OCT. The premise was that you're going from qualitative to quantitative. And I asked the question, well, if these machines are giving numbers and everybody's seeing the same numbers, regardless of whether you're a retina specialist, a general ophthalmologist, an optometrist, somebody on the street using Google search, what's your added value as an expert if everybody sees the exact same data? And not a single resident had a single thing to say about that question. And that really bothered me, that it was as if they'd never thought about it. Because I think this is a huge question, that as doctors, people do diagnosis and they do management. And for diagnosis, AI is really promising, but you need clinical judgment to collect the data. If you want to manage disease, well, that requires human connection to understand things like patient preferences. And I think that there's maybe the correct saying should be that doctors who use AI may replace the ones who don't. Because I think that one of my take homes is that we need to really understand the technology. Doctors need to understand that technology, and maybe maintain those uniquely human skills to do things like patient management. In other words, maybe that's going to be the added value of clinicians. But Emily Cole in Chicago and Thomas Huang in Oregon wrote up what I thought was a nice editorial in ophthalmology about how should the training systems that we have adapt to this type of system. In other words, what's the best way that we should be training doctors to have the skill set that they need in the 21st century? So my very last slide is that I think we've talked about 3 things: science, art, and technology. Here, science would be classification, clinical trials, and they've revolutionized care, but they're not perfect. And we talked about how diagnosis is subjective and qualitative. That takes us into art. Structured parameters, evidence-based practice, they cannot capture all that qualitative nuance of disease. And then the technology going from qualitative to quantitative. And I guess I'm just going to finish by suggesting that I think good care requires all of them, science, technology, and art. And I see that as being all of our goal together to figure out how do we combine those, to ultimately take better care of people. So thank you so much. And it's, great to, I'm going to turn my camera off now so so we can really see each other.
Thank you very much, Michael. This was wonderful. As people getting their thoughts and asking to, please send me a chat that you have a question. Let me start with my first question on that before we move to other people. Let's take OCT. The technology changed so dramatically, and you touch bases on that how we're going to integrate, even if today you're going to have a very large number of images, how are you going to integrate with the instruments which inevitably will come better quality images? Is there any hope of integrating those databases?
Chris, I really hope so. I think a lot of, there are many layers to your question. I think one of them is, how do we get the data out of the machines to do the machine learning? And that's not that easy sometimes. And I hope that one of the things that we can do is move toward a world where we can work with the vendors who build these machines to help us get the numbers out of those machines more easily to do things like decision support and AI. I think that's one piece of it. Another piece of it is that I think that you can do artificial intelligence, and that's great. But I think that we have to build these systems in a way that makes it easy for the doctors to use. And Chris, maybe this is part of your the premise of your question, that ultimately it's not going to be good enough to have a standalone system. The data has to flow. If the doctors live in the electronic health record system, my view of it is that the AI has to be built into the electronic health record system. Because that's where people are, working, if you will, and so that's an integration challenge.
Is there any chance of somehow digitize and have this some mathematical numeric values that they will be not that sensitive to changing the platform for images?
Chris, that's a probably better than anybody else that if you have two different devices, and if they're from different vendors, or even from the same vendor, like version 1 versus version 2, and you're trying to measure something like whatever it is, macular thickness, the numbers don't line up. In other words, you can't really translate, from one to the other. And I think that's going to be one of the things that so we talked about not being able to get data out of images. Another layer of that is that even if we do get data out of the images, are there things that we can do to standardize those numbers? And I would personally love to come up with a way to tackle those and to work with the community to do that. I mean, obviously I'm not the first one to have thought about that. But if you have, one of the things that I've been interested in is coming up with ways to really convene, the community to, really tackle this problem. And what can we do from the NIH perspective to stimulate this, or potentially even to require it. But love your thoughts about what that would look like.
Thank you. Brian.
Hey, Michael. Great talk. Thank you. So I've got a question. So I was at one of the early meetings in 2018 when Google was releasing their fundoscopic image data. And there's no question that AI works, and it works astoundingly well. But my question to the Google team at the time was, what was the feature space that that the AI was picking up on, and the answer was basically they didn't know, and their matrix was, I forget what the number was, 200,000 deep or something like that. And so I asked them, well, there has to be some way to reverse engineer this, right? And that was a no too. And I'm not sure I believe that. I'm not sure I agree with that. There has to be a way to sort of reverse engineer AI. But I guess my concern is that if we're turning over diagnostic decision-making to AI, if we don't understand what the feature space is that AI is picking up on, and it may not necessarily be the same feature space between AIs, even though they come to this sort of same agreement, because we're training them to do what we think we want the results to be. I'm just wondering if you can comment on that.
Yeah, Brian, great. Really important point. And it's something that I have struggled with for years. On the one hand, one could argue how many doctors actually understand how a CT scanner works, or for that matter, how an automobile works, and yet we kind of use them, and because they've been proven, the CT scanner has been proven to work, and so one of my fundamental questions is, does the doctor really understand, when a counter counts like what percentage of your blood cell is, when you're doing your blood counts, what, they'll just take the numbers because they believe them. And are we in a transitional point, or are we, is this, how important is this? I think but more, the thing that interests me about that is, I think explainable AI is basically what you're talking about. I think that it's important. And the reason that I would argue that it's important is, number one, well, maybe some doctors won't buy into it, or they'll need to be convinced because it kind of makes sense. I would say that one thing I would love to see is if explainable AI can tell us what it means for something to be wrong. Like as a medical student, I remember, very experienced ICU doctors saying, well, this patient is really sick, and they looked okay to me. And then they'll say, well, how do you know? And they'll say, well, I've just seen this. I've been doing this long enough. I just know. But the real issue is that they couldn't articulate it. They just knew it. And I think that's very common. Maybe these systems can tell us a little bit, what it means to be, and to kind of teach us in a way. But I think that this is really, it's an important issue, and I don't know that there's a clear, answer. And my guess is that answer is going to change, because we're transitional as our society becomes a little bit more comfortable, with the concept.
All right, let's move on. We have six more questions to come at least. And we will go with Josiah, Daniel, Susie, Anand, Dorota, and final word will go to Dr. Brown.
Dr. Chang, thank you so much for your time. This is such a fascinating lecture, really, honestly. Thank you. Great presentation. I had a two-part question. The first part being, how efficient can, maybe these are really basic questions, but how efficient can, for example, the algorithm that you use in your presentation, how efficient can that be? And then the second part is, as a two-part to that, second part to that is, what are your thoughts on using it on a mobile phone, for an iPhone, for example, utilizing the iPhone's neural engine, or I'm anticipating Google creating, they've already talked about it in the news a little bit, some leaks about how they want to put it in they're tightening the TPU chips, essentially putting them and mobilizing them onto Internet of Things. How, I was wondering if maybe you can comment on that too, and utilizing that for potentially increasing essentially the processing, because there's just, phones are so ubiquitous, but also even increasing the data sets that you can get.
Yeah, Josiah, great questions. You know, we've with efficiency, that's going to change based on the technology. I mean, what was efficient back in 2015 or 2016 when we started doing these deep learning projects is different now, because the nature of sort of computing and the price of GPUs has just evolved. But I think that the issue with mobile devices is really interesting as well. For a while we were, and actually still are, interested in this project. And it happens to be, we've got some friends and collaborators in India, and can we validate mobile devices there and just take narrow angle photos? But there's two questions. One of them is, does that give you the sufficient field of view to make a diagnosis? And the second is, to what extent can we extrapolate data from a wide angle camera to a narrow angle camera? And I think right now what we've found that we have to do is revalidate our studies using new cameras, using these small angle cameras. And so I guess in a nutshell, absolutely feasible in principle. We're only working on it right now, so I can't give data about it. But the preliminary data that we've got suggests that it works, and that what limits it is the preliminary suggests that it works. But I think that the thing that I'm struggling with more is I really don't want to see a world, and none of us would want to see a world where every time there's a new device, we have to repeat, the set of studies to just revalidate it, which kind of gets back to Chris's original question. And, I think that all of us would be well served by some standardization within the vendor community, along the lines of, there are some countries where when you plug your device into an outlet, the outlet's not the same depending on what city you're in, whereas in this country, they all look the same. And I think we'd be very well served by some standards like that governing imaging. And that's where I would love to see the community sort of moving a little bit, or maybe even a lot.
Hey, thank you so much.
Daniel.
Hi, Dr. Chang. I thought that was an awesome talk. I recently took a class at the NIH about machine learning and AI. And I thought this field is just so cool right now. And my question is, given like the spectrum of disease progression, would it be better to have a regression model instead of a classification model to give like the likelihood of disease progression? And would this be able to like help physicians catch disease early on and I guess have preventative medicine before struggling to deal with huge vision loss once the disease has progressed too far?
Yeah, Daniel, great. I mean, that's a good question. And in a nutshell, I'm personally not tied to AI compared to regression or compared to any of the other machine learning methods. It happened that for this particular system, what we did, and I'll just give a couple of the details, that what we did is that we build, so we've got a 1-to-9 scale, and we build deep learning systems, and the deep learning systems give probability of plus, pre-plus, or normal. And we basically, and those three sum up to 1, the probability of plus versus pre-plus versus normal. And we convert that to a 1-to-9 scale, very simple sort of, basically, equation to linearize it. We tried some things like regression and, ways that we could, different ways to train, and they just didn't work as well as doing that. But I'm trying to come up with, this is something that we're trying to tweak. Like, what's the best way to come up with it? And I personally am not tied to any of those methods. And as far as I'm concerned, AI is one of these tools in that armamentarium to go from qualitative to quantitative. It's a great point.
All right, let's move on to our newest Dr. Susie Su.
Hi, Dr. Chang. This is Susie from Polcheski Lab. Thank you very much for your great presentation. My question is, in the last part of your talk, you mentioned several areas that can be developed to improve the accuracy and utility of AI for the diagnosis of ROP, and which includes lack of standardization and image qualities and the lack of database. And in your opinion, what is the single most important area that's the immediate step to enhance the AI as a diagnostic tool?
Yeah, Susie, thanks for the question. And instantly, we were talking before this session, and we actually talked about your talk at Arvo. I thought you gave a great talk at Arvo about gene editing and LCA. I think that there are a lot of things that we could talk about as really important issues, but I think that if I had to come up with one, AI relies on data, and I think the single biggest question is how do we build large enough data sets to do this? And many issues come up out of that. It's like the standardization issue that Chris had mentioned, and where's the data going to come from? How are we going to get it out of the machines? But fundamentally, I'm going to take this in a different direction. Fundamentally, I think that we have a culture where the data set that I just presented was, quote, my data, that we spent years collecting and harmonizing and coming up with gold standards for. And there's a lot of tendency among investigators to say, well, gosh, I spent 8 years collecting this data set. I'm not just giving it to you. And I think that I understand where that comes from, but that is one of the barriers into my mind of how can we develop methods that truly incentivize data sharing in a way that, because everybody knows that it benefits the community, but it just doesn't benefit them individually. And I would really love to be able to tackle this issue of how can we truly incentivize that? It happens that there's a NEI, there's an NIH data sharing policy that's coming into effect in 2023. That's more of a stick approach, and I would love to come up with a carrot approach to complement that. And we're sort of trying with that, and I've got a few little ideas. But ultimately, I think data sharing is going to be one of the big benefits of this community.
Thank you.
Dr. Swaru.
Yeah, thanks so much for very illuminating talk, actually. I think, and bringing into focus something that is so important, but has not been talked as much in eye research. So you have actually answered some of the questions that I had in part during, during the last few minutes. But I think my comment or questions have a very nice segue from your last statement, how to get this thing going. And I have been always told that not only large data is important, but you need to have good data. So how do you collect standardized good data sets? And one of the things that I would suggest where NEI can take initiative is to maybe have sort of like clinical centers or cancer center kind of approach, that you have a bunch of ophthalmic centers around the country where you propose that everybody uses similar set of equipment for collecting the data, and all the data, and maybe even NEI can pay for some of that, and then that data set goes into a common sort of repository, which is then utilized for AI. And another approach could be to involve patients, where patients who are really participating in this study, they can, on their mobile devices, that's what you were talking about, they can sort of write their own symptoms and how they feel, and they can go on recording and then pass on that information to the database. So I think involving both the patients and clinicians would be critical in sort of getting large data sets, which are good data sets and reliable data sets. And that's what I thought. Maybe maybe you can comment on that.
Yeah, and great points, and good to see you here. I think that I really definitely love the idea of these centers collecting data in a harmonized way, if you will. In many ways, that's sort of the premise of this Bridge to AI project, that we develop those standards and get groups to do it. I think that one of my, what I would hate to see out of that is that if they've decided on what the standards are for the machines to use, and then 3 years later, the next machine comes out, it's the iPhone, 14 instead of what we've got, then what if the data representation changes, or you can't translate from the image that one machine created to the next one? I mean, that's sort of what I'm would love to avoid, needing to redo, the studies with each iteration of the technology. And I love the idea of patient collected data, and of integrating patients into this overall. I think the challenge is going to be creating a dictionary that they can use that's consistent. Of course, with patient-related data, patient-generated data, there's always going to be a little bit more fuzziness than with doctor-generated data. But in some ways, there's going to be benefits of it. Like doctor-generated data is going to be biased in ways that patient-generated data isn't. There's issues, racial bias, other sort of bias. If I collect something, I'll listen to a patient and I'll write down what I think I heard. And so maybe patient-generated data is going to be a way around that. But I think we're going to have to come up with ways to try to standardize, what we're getting from it. So, in a summary, I think that they're great ideas, and the question is going to be how to really do them.
Yeah, I think Michigan has done something along the line, and we can talk about it. Yeah, by the way, Chris has sort of organized this amazing series of seminars. So if you are not here, so I attend it every week, almost every week. So maybe whenever you have a chance, you should attend it. This is just awesome.
Yeah, thanks.
Let's move to Dorota and Tony and Brian and finish with Dr. Brown.
Hi, I'm Dorota Skłodowska-Krawczyk, assistant professor here at Center of Translational Vision Research. I would like to ask you a little bit about other things. As you mentioned, one of the first studies has been done to detect aging just by AI. And actually, aging is a really big problem, I think, in the eye field, as it is contributing to many diseases and problems. So I was actually interested to look in the draft of the NIH strategic plan and to see that there is a little chapter about the aging, but very tiny, but there is. And I actually would like to ask whether there are plans to develop it further, and maybe some collaboration with NIA.
Great question. And in summary, absolutely love to collaborate with NIA. I agree with everything that you said, and it's actually been on our radar screen for a while to try to build up closer relationships, probably for all those reasons that you're mentioning. Maybe there's going to be a potential, maybe that disease is going to be Alzheimer's disease, maybe it's going to be some other neurodegenerative disease, but I think that eye to brain access is potentially very, very interesting.
Thank you.
Tony.
So, Michael, a wonderful talk. For somebody that's an old timer, I know that the Eye Institute has ways to bring people into the field by saying, by developing grant systems that help to develop people that want to go into this field. We have 2 faculty members that are doing this right now. And what have you put together in order to help us bring people into the field in terms of grant support?
Yeah, Tony, I want to be sure I'm answering the question that you're asking. Are you referring specifically to training grants or early career grants, or something a little bit more generic in the field, meaning data science in general?
Yes, the broad support for AI as a contribution to medical care.
Yeah, yeah. Let me sort of address that with a couple of general comments. One of them is that in terms of what am I doing, since I've only been here for about 6 months, the answer to what I'm doing is relatively limited. But let me answer that with what I think is important, or what I view as priorities. One of them is that I think that we need, my view of it is that there's more data to be analyzed than there are people who are trained to analyze the data. That's one. And so I think we need more people. Another one is that I think it's not, so we need to come up with ways to train those people. A second one is that I think that these people that we're talking about, what they're going to be doing is they're going to be finishing up whatever training program they're doing, and they're going to want to get a job at Google or wherever, Microsoft. And what I see as our job is convincing them that they don't want to work at Google. They want to work at UC Irvine or Utah, wherever, wherever it is. And we're not going to do that by convincing them that Irvine pays them more money than Google. We're going to convince them of that by saying that they're doing work that matters. In other words, that curing blindness or being the first to do something is what should drive them in life, rather than your Google paycheck. And nothing bad about Google, but I think that we as a community would be well served by coming up with ways to message why we're doing work that really matters, because I think that that's part of, we have to train them to do this, but we also have to train to make them believe that this is work that's worthy of spending someone's life doing. And that I think my assessment so far is that that's a piece that I'd like to be a little bit more aggressive in messaging. I would say one last.
The NIH and the NEI have to, I think, come up with funding plans that help us recruit people to go into this field.
Yeah, and I think another issue is that I would love to build, like I made the point that some of these people that I've worked with over the years are what I'd call full-time data scientists. In other words, they don't have name badges that say Department of Ophthalmology. They have name badges that say, Department of Electrical Engineering. And I think that we've been well served by that, because I think it's brought a lot of ideas that I'm not sure I would have seen if they didn't work among engineers, or in some cases radiologists. And I think that there's something about that cross-disciplinary fertilization that I feel is going to serve us well as a community. So Tony, in a nutshell, definitely agree with the premise of needing to train more people. And those are some of my other sort of second level thoughts, if you will, about how do we get them in here, and what are the types of people that we would be looking for. But thanks for asking that.
All right, Brian Short.
Sure. I guess maybe this can't be short. My question was sort of based on what Michael thinks the future of AI is, right? In that sort of in the late 1940s, you know, the debate was, should we make machine learning AI like how brains work, or should we use statistics and linear algebra? And statistics and linear algebra won out, right? And so all the AI that we're doing now is basically that same math from 1948, just applied to bigger computational infrastructures. And there was that sort of AI winter that you showed in your slide from 66 to basically the 90s. And there hasn't been much in the way of advancement of AI in terms of algorithms for, I don't know, a decade. So I'm just wondering what your thoughts are on the future of AI.
Brian, I don't know the answer to that. I think it's I've definitely wondered about that also. Like, if I could paraphrase your question, are we going to have methodological innovation, or are we going to brute force more of what we're doing right now? I'm really not sure. I think from a different perspective, you know, one of the questions I think that we're going to struggle with as a community is it good enough to have discrete systems that do just one thing? I mean, diabetic retinopathy screening was a real triumph to be able to put these things out in the middle of nowhere. And do you have referral warranted disease? But it's really not what eye doctors do. It's what primary care doctors do. And I think we need to think that through. And, you know, we sort of, and that has a lot of implications also toward, you know, what's the workforce? I mean, what is the job of a primary care doctor versus an optometrist versus a general ophthalmologist versus specialist? And there are a lot of issues that I think that we're going to need to grapple with, you know, just sort of along the lines of, you know, what you asked.
All right, let's thank again, Michael, for wonderful presentation, many questions, a lot of discussion, but we would miss if there would be some final comments. And for those, we will go to Dr. Brown. He's in town.
Great. Yeah, thank you so much, Dr. Chiang, for sharing your undoubtedly very valuable time with us this morning. For me, it's been really nice to see your trajectory, as I'm an electrical engineer myself, and kind of over the 20+ years of your career, how it's evolved, and kind of gives me hope to have a long-term vision for my career. One of the things that I've encountered in trying to get involved in this type of field of data science and imaging is that everyone has got their own grassroots approach to just managing the data, organizing the data. They develop their own grassroots tools for managing the data or organizing it. And there isn't a kind of a unified system. Even within a university system as big as University of California, there isn't boilerplate management. And so that's why I work with a company called TII. Eric Buckland is a CEO of started by Ophthalmology, and I was doing this because they're promising a generic solution for vision science. And so that's kind of what I'm imagining might be a way of lowering barriers to people starting a data science career or AI career or whatever, is to have a centralized source where people can opt in or opt out to make the data someone else's, keep it for themselves. Because, you know, you mentioned this whole idea of territorialization of people's data and their time, and I understand that, that's fine. But to lower the barriers for someone to say, okay, I have my data, I need a way to organize it, here's where I'm going to put it, and I can give permission or not give permission to the NEI in this case to manage that data, and then also offer tools for analyzing the data. You know, ImageJ was such a huge success, and so basically that kind of low bar and low barrier to entry is, you know, I don't know if there's anything else in science that's as free and hugely and ubiquitously valuable.
Yeah, great points. I know that Eric has been interested in that, and I've never seen the system that that you guys are doing, but I really love the premise of being able to exchange or share. I think that question that I'm less sure about, in fact, I'm not sure about at all, is what our best approach is in terms of getting to that world. I mean, one approach is going to be a centralized system, like I think you presented, sort of opt-in, opt-out. Another approach would be creating those standards for data exchange, sort of like a HTTP world, if you're more of a federated approach. And I think that there's advantages of both of them. And, one of the things that we're going to have to figure out as a community is which way we're going to go with, really promoting data sharing. One of the things that you mentioned, that within the UC system, there's heterogeneity in terms of, same at NIH. There's a lot of individual systems that kind of do the same thing among the different institutions, and nobody really likes that. But we're gonna, we're gonna have to come up with a way to, to really facilitate sharing. And as I see it, the options are that it's going to be some centralized repository, or it's going to be some set of rules for federated, data sharing.
Thank you.
Thank you very much. All right, so I will see you next Friday, 8:30, the same place, the same time, the same electrons will be projecting a talk from NIH and other scientists from NIH. See you then.